Finding Hope, the Road to Recovery.
Hi, my name is Dr. Amita Fakhimi. I'm a clinical psychologist. I work as a narcotic treatment program clinical supervisor at Tarzana Treatment Centers. We're here today in our Finding Hope, the Road to Recovery segment to discuss the opioid epidemic and utilizing harm reduction as a tool. I'm here today with my guest, Dr. Karl Kaplan. Dr. Kaplan, would you like to introduce yourself and tell us all about your background?
Thank you, Amita. I'm only too happy to say that addiction medicine has really shown me to be one of the more important aspects of providing total patient care. Mm-hmm. When you think about it, in primary care, where I was for more than 35 years before moving into the field of addiction, I often saw that a lot of my patients' problems, they look to solve by taking controlled substances. And finally, I decided to get on the right side of the problem and be able to provide them with the best medications we have for these conditions. And that includes alcohol as well as opiate substances. So, you know, most people don't realize that this started as a problem largely of our own making, our own meaning physicians making, because patients were coming to us. Pain was being overemphasized as a fifth vital sign. And so we started to loosen up our treatment of patients who complained of pain. And that unfortunately spilled over into abuse and deaths from overdoses.
Yeah, and I think that's a really good introduction on how did we get here, right? How did the opioid epidemic take place? I'm curious to know, Dr. Kaplan, in your work as an addiction specialist, what has been the biggest revelation that you have experienced in working with patients?
Well, you know, I think that it's very important that you engage the patient and that you talk to the patient, you don't talk at the patient. And it's very easy to tell when the patient is getting interested in the conversation. So I like to start my conversations by telling them, you're never going to meet a better drug dealer than me. And let me tell you why. Number one, you can't beat my prices because you're probably going to have this paid for. Number two, you can't beat my quality. I know what I'm giving you. There's nobody stepping on your drugs. They're the best. And number three, once everything is fine, you only have to see me once a month. How often do you have to go see those people in the back alleys? You know what I call them? Amateurs. You come to me, we've got the right medications, we'll be happy to provide them to you as part of your global health care. Because this is a very important aspect of health care that gets overlooked in primary care. Primary care physicians are just too busy to give the depth of psychological support that these patients need. That's why we have the psychological support that we offer.
And I really appreciate that perspective and branding yourself in a way where you engage the patient by, you know, getting into their world, getting into their, utilizing their language. And, you know, for our audience today, maybe providing a little bit of background on how the opioid epidemic even started about 20 to 25 years ago in treating pain. Opioid medications were utilized heavily, marketed heavily by different pharmaceutical companies and kind of just pushed to the public. And in and if you, what is your experience in working with the opioid epidemic and treating patients?
Well, the sentinel change was when the makers of OxyContin put it forth as, if you take our product, you will not develop opiate dependence.
Right.
Because it's a slow-released product. So what will happen if you use it as directed, you will not get euphoric, but you will become opiate dependent.
Yes.
And people quickly learn that if you cut it up and snort it or inject it, that you will get euphoric.
Yeah.
And that was a bitter lesson for us to learn. And unfortunately, it became the springboard for fentanyl, which has just shot overdose deaths through the roof.
Yeah, in 2022, there was over 100,000 deaths due to overdoses. And fentanyl has become such a problematic drug because it is, it's not easy to detect. It doesn't have any odor. It doesn't, and it's the potency of it is so high, and it can be laced into any unregulated.
As they say, when you put these drugs in the hand of an amateur, you don't know what'll come out. And fentanyl is a very useful medication when used appropriately. But the problem is when you turn it over to people who don't really care what they're selling, that you're going to get a batch that you weren't ready for, and it's going to kill you. And obviously, as a physician, we're dedicated to trying to preserve life. And I think one of the big changes that needs to come about is for the physician to be able to see patients who have alcohol or opiate use problems is they have what I would call a relapse disorder, similar to a seizure disorder. If a doctor sees a patient with a seizure disorder, they give them medication to control the seizures. They tell them if you don't take the medication, you'll probably have a seizure. In this case, if they don't get the medication to prevent the relapse, they're going to relapse. And if they don't continue to take the medication, then they're going to be at high risk for relapse. And, I think that's, probably a good time for us to talk about the medications that can be offered through an integrative health program like Tarzana has.
Sure.
So we have 3 main medications that we use for addiction treatment. And those 3 medications are for patients with 3 different levels of needs. The medication that we like to use the most for opiate use disorder is called buprenorphine, or it was branded originally as Suboxone. And this goes to the same opioid receptor as the illicit drugs. It doesn't give you quite as much stimulation, but it's very long acting. So instead of feeling high, you just feel good. And you feel good for a while because it's long acting. And the physician is there to work with the patient to titrate the dose till the patient finally says, I don't feel any desire for any opiate medication. And the nice thing is that even if someone were to give them an opiate, the Suboxone will not give up its space to the opiate, so the opiate's not going to do anything. So Suboxone is a fabulous medication, very safe. You can't overdose on it by itself. It's our first choice for patients with opiate use disorder. Now, if the patient finds that Suboxone is not appropriate for them, we can move in one of 2 directions. If they need more stimulation, we have methadone available, but methadone comes with more inconveniences. You're going to have to see me more than once a month if you're on methadone. However, if it works for you and it is used as directed, it's very safe. And then if the patient feels that they want less stimulation, We do have naltrexone available, also available as a monthly injection, Vivitrol. And that blocks the opiate receptor and gives you no stimulation, so you just feel undrugged. And the beauty of the naltrexone or Vivitrol is that it works fabulously for alcohol problems. When a patient drinks alcohol, we feel that they release their own opiates called endorphins, and those go to the receptors, and then they get their reward and they feel better. By giving them this medication, as soon as the receptors are filled, they have no desire to drink. And if they do drink, they don't get any reward, so they don't want to drink. So just in that one medication, we could eliminate a huge amount of alcohol use disorder, but we have to get the education out there, both to the physicians as well as society in general.
And Dr. Kaplan, you gave a really good intro for those who are unaware of the different types of medications that are used to treat opioid use disorder or alcohol use disorder. And I think thinking about how do we get past this opioid epidemic, medications are certainly a big part. And it helps us move from, having this mentality where you feel like you're stuck in the problem and we're in this opioid epidemic, and what do we do? How do we move forward? Medication can certainly be a solution to that problem. And I think in addition, thinking about the behavioral approaches, treating the patient through the whole person care approach, looking at not just their physical, physiological, medical needs, but also their behavioral, psychological, community, and rebuilding or introducing habits and behaviors throughout the day that treat the whole person and not just, here's a medicine to address this issue. As I've heard you say many times, medicine alone doesn't do it.
Yes, we would like to think that we're just machines, but we have emotions. And I think one of the big problems is this concept that's come out called emotional intelligence. That, in other words, you might have a doctor who is a wonderful surgeon, but he can't control his temper. That would be an example where emotional intelligence is lacking, even though physical and other forms of intelligence are there. So we have to, in taking this integrative approach to the patient, try to help them learn how to have better relationships. I feel that all addictions are love substitutes, but people really don't know how to love each other. If you think of love as just being nice to each other, caring about, that person's well-being, even if it's not, specific. In that comes just as much healing because we don't appreciate that people are lonely. And people are not designed to be alone. We're designed to live in communities where we support each other. And we've sort of lost that. And as a result, we're feeling emotionally uncomfortable. So we go and seek out something to help relieve our discomfort, when really we should be seeking relief through community.
And through community is where you think about, how do I get access in my community to treatment? And what you and I have seen is and are the barriers to treatment. The reason why harm reduction is so great is because it eliminates those barriers to treatment and looks more to, if I want to get medications, if I want to get behavioral health interventions, if I want to get mental health help and treatment, I'm able to without having to jump through all these hoops, and allowing the medical provider and the clinician to be able to give that help to the patient in our communities without having to jump through those hoops. And I think the reason why we identify with Tarzana Treatment Centers as such a wonderful center to help is because it provides a multitude of treatments, including detox, inpatient, residential treatment for patients, a multitude of outpatient programs, youth programs, a syringe exchange program. We provide harm reduction kits to patients. We provide Narcan to patients. You can literally walk through the door and ask for a Narcan and walk out without having to go as though you would do it through a pharmacy where you have to sign your life away. That kind of having access to treatment is so important in our community, in our society, and at large. I think it could be a really good way to implement help through all communities in the U.S.
Well, just by your description, you can see why this would be difficult to integrate in a small medical practice.
Mm-hmm.
You really need something that is large enough that it can be specialized, where you assess the patient. You said, based on my assessment, the patient needs this, which when it comes to getting psychological care as a primary care physician, they made it so difficult that both the patient and physician gave up on it before it got anywhere. But fortunately, by lowering the barriers to entry into these kinds of programs and having professionally managed programs readily available under the same roof, makes the whole thing synchronize better, because there's a common philosophy behind each aspect of the care offered to the patient.
Mm-hmm. Mm-hmm.
So that, to us, this model offers to give us a happier patient, which
Mm-hmm.
is more likely to lead to a healthier patient in terms of getting the necessary preventive services done. But not only that, there is a lot, as they say in country music, that goes on behind closed doors. Mm-hmm. And we've got to start acknowledging that, hitting people is wrong. And many other changes that it's very hard for us to let go of, because
old habits die hard.
More people probably remember "spare the rod, spoil the child" than we want to. Mm-hmm. I mean, it's funny because when the parent might be spanking the child, says, "This is hurting me more than it's hurting you," mm-hmm. and the child looks up and says, "No, it's not."
No, it's not. That's right. It's not.
So but again, the kind of people that want to hit their children are people who are emotionally unhappy. If we address their unhappiness, they become happier, they stop hitting their children. The whole thing falls into place. And the common underlying theme is you have to care about your patients.
Mm-hmm. Mm-hmm. And compassion and meeting the patient where they're at is our next segment's focus.
Okay. That sounds great.
So, our dear audience, we're going to take a quick break, and we'll come back, and in our next section we're going to focus on harm reduction strategies from the medical and clinical perspective. Welcome back to Finding Hope, the Road for Recovery. I'm here back with our doctor extraordinaire, Dr. Karl Kaplan. We are discussing the world of harm reduction and how it can be utilized to treat this opioid epidemic that the country has been facing. So, Dr. Kaplan, we talked a lot about the problems that we have with the opioid epidemic. What would you say are the kind of changes you would like to see to treat this explosion of opioids that have been in the streets? And what would you say, as the expert in the field, would be some of the changes we could see?
You know, I think one of our biggest problems is our tendency to stigmatize others. Mm-hmm. In other words, if we see someone who's less fortunate than us, mm-hmm. I think instinctually that makes us feel better. Mm-hmm. And so, but we have to sort of change our thinking to one of what can we do for this person in order to improve both their lives and the lives of the people around them. Now, this has not normally been the purview of the primary care physician. The primary care physician gives them medications for their blood pressure. If their blood pressure is not controlled, then they try to give them more medications, even though it's probably because they're not taking the first medications that they were getting. Mm-hmm. People don't really like going to doctors. It's not been associated with being a pleasant experience, and I think we've got to make it a more welcoming experience. I think it's very important that we don't overburden our primary care physicians, but we need to make them very aware of the resources that are available to them through facilities like Tarzana Treatment Center, mm-hmm. where they're going to take that extra step in that dimension of patient care that the primary care physician simply is not well suited to address. Mm-hmm. And I think that if we can also see our patients that have substance use problems as a medical condition, mm-hmm. that this is not a choice, mm-hmm. any more than I tell patients that being fat is not a choice. Mm-hmm. Mm-hmm. And so the thing is that once we recognize that it's not a choice, the next step is, what do we have to offer for treatment? Mm-hmm. And, you know, until recently, we didn't have too much to offer, so we had to put it back on the patient. Mm-hmm. Mm-hmm. But now we have great medications to offer them. We see to it that the financial barriers are taken care of. And we want to let the primary physician know that you don't have to necessarily treat this in all its depth, but know that there are places where the patient can go to receive that kind of multidisciplinary, integrative, whole person treatment, which is really the way we're going in the future of medicine.
Yeah, and you know, the fact that Tarzana offers that you know, whole person care approach where you can receive medical services through primary care, you can receive mental health services, you can receive medications for addictions treatment, you can receive behavioral health services, you can receive counseling, you can receive peer support, detox.
And all these people are talking to each other.
Yeah. And
so that it's, because, you know, addictions are about bad relationships. Mm-hmm. You have a bad relationship with a substance or a behavior. And so we have to teach our patients how to have good relationships. Good relationships include good communication and good boundaries. So if we can model that for our patients and teach them that, they will have much happier lives.
And in regards to utilizing harm reduction, so what is harm reduction? Harm reduction is an evidence-based approach that minimizes the adverse health outcomes to the patient because you meet the patient where they're at. You don't utilize kind of like that old school mentality of, I'm going to tell you this specific way that you are going to never use drugs again. And if
That's
you
right.
don't do my method, then you get no treatment. And I think part of harm reduction is, a big piece of it is our view. How does society look at someone who's struggling with addiction? We utilize negative language. We utilize words that have negative connotation, like addict, heroin addict. You're not clean.
Yes.
You are, you're
You're a drunk.
You're drunk. And that in itself, as not even as a clinician, but as a person functioning in society, there is such a negative, the way we look at addiction is with such a negative connotation, because I think the general public, people in society, normal people in society, are uncomfortable themselves with the notion that somebody else has this disease that is, well, go over there and get your...
Or that they might have it and they have to hide it because people will disparage them for it. And they're right, people will disparage them for it. And I always tell my patients, please don't wear a T-shirt that says I take Suboxone or ask me about Suboxone. It is nobody's business but your own and those who need to be involved with it. And I think that if we can just accept the fact that we are so imperfect, we can become more perfect. But until we accept that fact, we're trapped in this web of denial, you could call it.
Yeah, and we're definitely thinking of ourselves as a work in progress. We learn something new every day. And treating that discomfort that we have when it comes to treating patients. For example, I think one of the biggest takeaways from harm reduction is that maybe somebody thinks the fact that you would have a needle exchange or offering clean syringes for people to use their drugs, but use it in a safe manner. Providing fentanyl test strips where somebody who utilizes drugs can test their drugs and make sure it isn't laced with fentanyl, so it avoids overdoses. They're provided with Narcan, so if an overdose happens, it's easily reversible within minutes.
Yes.
And so these are all different pillars of the harm reduction model, and saying, you want to walk in through the doors, here are all the tools that we can provide you with that. So with that, I'm wondering, when we have such a evidence-based approach at our disposal, why would you say the medical community struggles to implement this into their practice?
I think that because addiction is very complicated, because I believe that it's a psychophysiologic, sociocultural, spiritual disease. Just by that description, you can imagine it's not taught in conventional medical school. And the thing is that people are designed for survival, and in many cases, survival behaviors are the opposite of the behaviors that we would encourage in the environment that we're in now. We're still primitive compared to how far we've come in terms of the comfortable lives we live. We're uncomfortable with that level of comfort. And this is why you wonder, why do people want to live on the street? They were designed to be survivalists. They don't mind living on the street. And yet, we can give them so much more if they would, but we have to a lot of times patients treat themselves badly because they don't see any value in themselves, because when they were raised, they were told they were not of any value. But we want them to know that that was a lie. They are of value. And if they will come in, we will show them how they can have happy, productive lives. But in some cases, they will need medication in order to fully appreciate that.
Yeah. And in your statement, there's a lot of, it's filled with the need to engage the patient. And maybe 5, 10, maybe even a couple of years ago, engagement was based on certain criteria of, you're going to agree to these rules. And if you use drugs, you're bad. And there's this like disdain for failure, right? And
even though we hold them to a much higher standard we'd hold ourselves to.
Yeah. And relapse is equivalent to failure.
Yes.
However, through this harm reduction lens, what is my job? My job is not to judge anybody who utilizes drugs. That's not my job. My job is not to judge you or put you down or tell you what to do. My job is to help you make the most well-informed decisions that you can. My job is to assure that you are aware of the risks in your behaviors. And my job is to not take it personally as your clinician, as your healthcare provider, as your counselor, as your nurse, that you're
making me look bad.
Yeah, that it's about me, which is also another big piece of addictions treatment, where it's taken as a dagger through the heart, and you relapsed, so you failed us, our cohort, our community, and it's not about me.
Well, the treatment provider sort of takes on the role of a parent, and the parent is telling them, listen, I didn't have you to make me look bad. I want you to make me look good. And if you're not making me look good, I'm not happy with you.
Yeah.
And so as opposed to saying, my child, you're having a problem. How can I help? But that's not in our nature. That's why we have Jesus.
So, Dr. Kaplan, in utilizing harm reduction, in the medical community, what would you say is needed to assist medical providers do their job more effectively?
Well, we have to understand that any time a person is subject to severe stress, they're going to develop compassion fatigue. And this becomes very problematic in the treatment of these emotional behaviors. And we don't want if the physician is going to take a posture of, this is not my job, we want them to be aware that there are places in the community where this is their specialty. And we would welcome referrals of those patients so that we can offer them the treatment they need. And just as an eye specialist or some other kind of specialist might offer to patients. But at this point in time, we just sort of have the distinction of psychiatry and medicine, but addiction medicine sits right in between, because most psychiatric conditions are not that common as addiction problems are. And in fact, if I were to tell you, most of my medical training was learning how to treat the complications of addiction, be it smoking, overeating, or alcohol or other drug use. I mean, that is internal medicine. You learn how to take care of people who are destroying themselves with these substances. So if we could just get them to be on either no substances or even just a healthier substance, it's all relative. Harm reduction comes in when you say to yourself, is my action going to make life better for this patient? And nothing to do with, this patient is doing something that I consider immoral. I'm not the one, I'm not God. I'm not the one to stand in judgment. My role is to heal. And if I can't do a complete job of healing, then I'll have to do a partial job of healing. But if my actions make life worse for the patient, then I probably should consider not doing it.
Right. And so increased education, increased training to allow the medical provider and, in my world, the clinician, our counselors, our peer support specialists to be able to feel comfortable treating the population they're treating. And one of the aspects of minimizing and reducing the negative impact of addiction is being able to have a patient walk through the door and making them feel comfortable, not making them feel punished, or as you said, we discussed earlier, not feeling judgment. Being able to, if a patient is homeless, being able to provide them with homeless services where they can gain shelter. If they're a smoker, being able to provide them with treatment for their
options.
Yes, nicotine addiction. If they have high blood pressure, if they struggle with mental health, being able to kind of treat all of those. But I think to start, it requires the ability of a medical provider and the clinician, the nurse, the counselor, any that full staff that you have to build rapport with the patient. And I've seen this as a strength of yours, where a patient will come in and you will meet them where they are, not make them feel judged, and if anything, say, I'm on board with what you want to do. Let's do it in a healthy way. So how would you say is an intervention or a skill or your experience with being able to build rapport with patients? And I think in the medical community, it's called bedside manners, but I think it's a lot more than that.
Yes, but we've lost the bed. So, no, I think it is very important that the patient wants to be there. In other words, it's like going to the teen club. You're going there to see people you enjoy, people who make you feel better about yourself, and people who also remind you that life is a struggle. But once we acknowledge that, it gets easier. And once we have people around us, it gets easier. There's a biblical expression that whenever two or more people are together, that God is there. But it also says that when you're by yourself, God's not there. And the worst thing you can do to a person is isolate them. And the saddest thing to see is a person in a crowd of other people who still feels isolated. And it's because they either have mental health problems, which have gone unrecognized and need attention, or they've simply been treated without the dignity they deserve. And
I love that word, dignity.
We need to recognize that everybody has something to add. And if we can just have that kind of feeling towards others, I mean, people, I think, are a little uncomfortable with it because they associate that feeling with having to be in church, and they didn't like being in church, but really it's about spirituality. It's about being open as opposed to being closed, being compassionate as opposed to being contemptuous. And
making them feel like a person, not just another, prescription pad.
Yes. And we don't have to worry about you surviving. You're going to survive, but now we want you to thrive. Now we want you to be happy. And we want you to learn how to treat other people in a way that'll sustain your and their happiness. I tell people, I want you to go from being the pinball to being the flipper. I want you to learn how to control the situation so that it has a good outcome. Because the most destructive thing we have to deal with in our society is anger. When people get angry, they get crazy. And so we have to teach people how not to get angry. Well, how do you not get angry? Don't expect so much of people. We really expect too much of them. And so
essentially what I hear you saying is, although, you know, when I want to go to the doctor, I don't necessarily look forward to going to the doctor, unless it's you, of course, Dr. Kaplan. So what I hear you saying is creating a safe environment for the patient so they feel comfortable. And, you know, from the clinical perspective, making that rapport, that safety builds trust. And so over time, that trust will allow you as the medical provider, or in my case, as the psychologist, or for the counselors in their counseling, for the nurses in their work, to be able to provide and advise less risky behaviors, healthier coping patterns, healthier communication interventions for the patient to be able to thrive.
We have to try to be the example of what we want them to become. And in doing that, we get to benefit from the community that we build because everybody on the team, you know, the old model was the physician was like the king, and then everybody served what they wanted. But we've gone to a new, more democratized model where the physician has their area of authority, but then so does the social worker, so does the psychologist. And so by sharing that responsibility over this community of interested providers, the patient gets to experience the, I would like to call it the affection, support of all these people, just to just let them know you are okay.
Yeah.
And if you're not okay, you're no more not okay than the rest of us.
So, Dr. Kaplan, I want to thank you for being my guest today, and for all the advice and clinical expertise and medical expertise that you bring to patients that you deal with on the daily basis. And I want to thank the audience for joining us today. Thank you. This has been Finding Hope, The Road to Recovery, part of Tarzana Treatment Centers segment today on opioid use disorder, alcohol use disorder, the pandemic, and utilizing harm reduction to address the needs of those patients. Thank you for joining us. We'll see you soon.
Brought to you by Tarzana Treatment Centers. You can visit our website at www.tarzanatc.org or call 1-800-996-1051.